Assalamu alaikum. The long clinical consultation day. First scenario, Mr. Daniel Harrison, 52 years old, male, presented with vomiting for the last 3 days, along with the deranged liver renal function test, high urea and creatinine. Vital signs are normal. Please take history, examine the patient, address his concerns. Here you go.
Okay. Hello.
Hello.
I'm Dr. Ahmed. I'm doctor in the clinic today. Can I confirm your name and age, please?
My name is Mr. Daniel Harrison, and I'm 52 years old.
Nice to meet you. Today we are here to discuss some issue related to your health condition, examine you, and address your concern. Is it okay with you?
Yes, it's okay, doctor.
Can you tell me what brought you to the clinic today?
Okay. So doctor, I've been feeling quite unwell for the past 3 days. I was getting sick and I started vomiting. It happened around 4, 5 times, I think. And then I went to my GP in the first day, and I thought it was something related to like some food I ate. But despite hydrating, despite taking some medicine, still it's not going away, and I'm feeling more and more tired. I had some blood tests, and they said my kidney function is on the high side, so I had to come here for a further evaluation.
Okay, I'm sorry for that. You mentioned that related to food. You mean you eat something and then you develop vomiting?
Yeah, so I had a takeaway. I initially thought it could be related to that, but it was still unsettling. So I'm not sure because my GP said it's probably something else apart from the food I ate.
Okay, sorry for that. Uh, can you tell me, this vomiting contain any blood?
No, it doesn't have any blood.
Okay, large amount?
Yes, it's large. I can't quantify, but maybe at a time when I vomit, it's like a 1 cup maybe or less.
Okay, only 1 cup.
Yes, it's like 1 cup. Yes.
Okay, okay. Is there any tummy pain?
Yes, there's tummy pain as well, and I was also quite troubled with the tummy pain, so I took some painkillers, and it's also not settling.
I'm sorry for that. How you feeling now?
I'm feeling well now. It's just it comes in episodes.
Okay. Can you tell me what is the site of this pain?
So the patient is pointing to the epigastric area. It's in my upper tummy, doctor.
Okay, okay. Then if you grade it from 0 to 10, like, or from 1 to 10, 1 minimum, 10 maximum, what grade you will give for this pain?
I'll give it around 5, doctor.
Okay. What is there anything to increase this pain?
No, I did not notice anything.
Okay. Is there any something relieves this pain?
No.
Okay. Also, is it started for 3 days with the vomiting associated with?
Yes, these are happening at the same time.
Okay. 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 Uh, is there any loose motion?
No loose motions.
Okay. Is there any feeling sick?
Yes, I'm feeling sick.
Okay. Uh, uh, is there any difficulty swallowing?
No difficulty in swallowing.
Tummy distension?
No.
Okay. Is there any change in your water work?
Yes, doctor, I felt the amount of my waterworks is getting less.
Okay. 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 Is there any change in color?
And no change in color.
For the urine?
No, no frothiness.
Okay. Okay. Is there any other symptom associated with this?
No, there's just the vomiting and the tummy
Okay.
pain, and also my waterworks
This is
getting.
first. Okay. First time?
Yes, this is the first time to happen to me.
Okay. 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 Is there any joint pain,
No joint pain.
skin rash?
No, doctor.
Okay. Is there any high body temperature?
No, doctor.
Any change in your weight?
No, not recently.
Okay. Any lumps or bumps in your body?
Yes, doctor. So I've had some lumps and bumps recently, and I've been evaluated for that. This was few months ago, and I've been diagnosed with lymphoma recently.
Okay. This for how long before?
So I've been diagnosed around 5 months ago.
Okay. Now on any medication for this?
Yes, I'm still taking some chemotherapy for my lymphoma.
Okay. I'm sorry for that. Okay. You are take your chemotherapy regularly?
Yes, I do take it regularly, yes.
Okay.
And I'm
Okay.
following up with the cancer doctor.
Okay. You are on regular follow-up.
Yes, I am.
Okay. Other medication than chemotherapy you take?
Uh, no, I don't take any other medications.
Okay. Is there any is there any neck swelling or any lumps in your leg?
Where?
Neck in your neck?
No, in my neck, no, I don't have any swelling. You mean in front of my neck, there's no swelling?
Yes, yes, yes. Okay. Is there any weather preference?
No, I don't have any weather preference.
Okay. Is there any headache?
No, doctor.
Any weakness?
No,
Any memory problem?
no,
Any vision problem?
no.
Okay. 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 Can I ask you uh, some social question?
Yes, please go ahead.
What do you do for living?
I'm a school headmaster. I'm the principal of a school.
What?
I'm uh I'm a school headmaster, or I manage a school.
Okay, school manager.
Yes.
Okay. Okay. Um, do you smoke?
No, I don't smoke, doctor.
Do you drink alcohol?
No, I don't drink alcohol.
Is this symptom impacting your life?
Yes, doctor. I haven't been able to go to school for the past 3 days.
I'm sorry for that. I will give you sick leave until we fix your problem.
Thank you for this.
I want to ask you some question. Sorry. Um, no any shortness of breathing,
No,
no chest pain,
no,
or feeling of raising of your heart.
no,
Anyone notice that you are paler than before?
no, doctor.
Okay, thank you. Can you let me to examine you?
Yes, okay.
Okay. I want to check hand for
Okay.
any clubbing, any colonychia, leukonychia.
No clubbing, no colonychia, no leukonychia.
Okay. I want to check neck for any lymph node enlargement.
Yes, there are some lymph nodes enlarged in the neck.
Okay. Okay.
Anterior.
Tender,
No,
not tender.
not
Okay.
tender.
Okay. A smooth rubbery.
Yes. Smooth rubbery.
Okay. Okay. I want to check eye for any color jaundice.
No jaundice, no pallor.
Okay. I want to check also mouse.
Okay. What
Yes,
do you want to check the mouth?
for any ulcer, for any candidiasis,
No ulcer, no candidiasis.
no gingival hypertrophy.
No.
Okay. Then I want to examine abdomen.
Okay.
Uh, Inspection. Is there any scar?
No scar in the abdomen.
No distended vein.
No.
Okay. Superficial palpation. No lumps.
No. Superficial palpation is normal.
Okay. Deep palpation for organomegaly, liver.
No. No
Is
organomegaly.
okay. Spleen.
Spleen is not palpable.
Okay. I need to do also liver span and also measure size of spleen.
They're both
Liver
normal.
for okay for kidney palatable.
It's not palatable.
Okay. I will listen also for heart first and second heart sound and if there is any murmur.
Cardiovascular examination is normal.
Okay. Okay. Um. Okay. I want to see also vital sign for pulse and blood pressure.
Okay. So these are the same as outside, the same as they have been given. So your blood pressure is 105 over 60, and your pulse rate is 90, and it is regular, and you found a postural drop.
Okay. 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 Thank you. Um. Okay. Um. Okay. Thank you for letting me to examine you. Finish. I know I forget past medical history. I can ask it now or
Yes,
خلاص?
go back to your past medical history.
Okay, past medical is there any past medical history?
So doctor, I have this lymphoma, and
Yes, I
as
know.
I
About
told
other than
you, I'm still on chemotherapy,
okay,
and my last chemotherapy was a few days before I started to develop these symptoms.
okay, okay, okay. Thank you very much. Thank you. Do you have any concern?
Yes, I'm quite concerned, doctor, about this because still my vomiting is not settling, and I'm not sure what it is. And I'm also
Two
very
minutes
concerned.
left.
I'm very concerned
Okay,
also about my kidney function. They said there's something wrong with it.
okay. So from history and examination, and you have vomiting and tummy pain. I suspected me have most likely you have infection. Maybe it will be neutropenic sepsis or um, or uh, other viral infection. Mostly this is related to chemotherapy.
Okay.
Is it okay with you?
Yes, doctor. I just want to know how are you going to manage me? What's the plan?
Need to admit you and need to um, follow up of you and repeat renal function after good hydration and giving according to infection, according to type of the infection after doing what is called CBC. This is a blood test we need to order, and we need to order also full investigation and repeat also renal function. And after determine type of infection after investigation, then we will give accordingly antibiotic.
Okay.
Okay, and we will support you by giving fluid, antibiotic if there is fever, symptomatic treatment.
Okay.
Okay. Do you have any other concern?
Doctor, you said you want to do some investigations and then you give me some treatment. Am I going to stay in the hospital or I can take the treatment back home?
After investigation, and we determine type of infection. If there is infection, maybe need to give you for 2-3 days in the hospital until you are stable and renal function return back to normal. Then we can discharge you.
Okay. Thank you, doctor.
Thank you.
Okay, time is up. Examiner questions.
Okay. Please summarize your case and give your positives.
Okay, I have examined 25-year-old, presented with vomiting 4 times per day and feeling sick and tummy pain, mainly in the upper tummy. Pain scale is a 5, and also because of this vomiting, there is less urine also, and there is lumps and bumps in all over the body and mainly in the neck. And the patient is known case of lymphoma for 5 months ago, now on chemotherapy, last dose before 10 days, less than 10 days before. Okay. On examination, there is lymph node enlargement in the cervical area. And also there is postural drop in the blood pressure.
Okay. What's your differential diagnosis?
Neutropenic sepsis.
Okay.
Or cytomegalovirus infection.
What else?
Uh,
Anything that can happen as a complication of chemotherapy in this patient, given the temporal association that he had chemotherapy just a few days before developing these symptoms.
Other than infection?
Yes, other than infection. And particularly with this type of cancer?
You mean, but no skin changes? No skin change, no weight loss. So I didn't suspect cancer other than lymphoma.
No, I meant any complication that can happen, especially in lymphoma patients, just few days after taking chemotherapy. One of the side effects or complications in lymphoma.
You mean complication of chemotherapy?
Yes, it can happen, a complication of chemotherapy, particularly in blood cancers, in lymphoma, in leukemias. Okay, how are you going to investigate your patient?
Basic investigation, full blood count, renal function test, liver function test, inflammatory marker. Then viral screening and also I want to see also I want in CBC I want to see differential for neutrophil count.
Okay.
Then also I will do blood culture and urine culture.
how are you going to manage?
Uh, Admit the patient, giving IV, uh, firstly, non-pharmacological treatment, counseling and education of the patient about condition, multidisciplinary team approach, by chemotherapy, by hematology doctor, and also a gastroenterologist, and a specialized nurse. And then we will support the patient by IV fluid and follow-up of renal function and treat according to type of infection.
Okay. Okay. If you do, have you considered to do an ECG for this patient?
ECG.
Yes. A patient with deranged renal function, what other things the patient could have, like with deranged renal function? Are you considering any
Yes,
electrolyte?
yes, yes, yes. We can check. Yes, we'll check for can happen disturbance in potassium, and also may develop also if go into renal failure, may develop uremic pericarditis or uh, pulmonary edema.
Okay. Have you considered tumor lysis syndrome as a complication in this patient because of his chemotherapy and the background of lymphoma?
Yes, yes, can be. Yes, yes, yes.
Okay. What abnormalities are you going to find in tumor lysis syndrome?
Mainly affect. Mainly, we will find in renal function. Okay.
Okay.
Uh, then we'll find also electrolyte abnormality in potassium and phosphate, and also high uric acid will be found also.
Okay.
And will be present as this case by acute kidney injury and arrhythmia and sometimes seizure also.
Okay. No further questions.
You can ask her how to manage the tumor lysis syndrome per se.
Okay, I just thought my 5 minutes are over for the examiner. So, how do you manage tumor lysis syndrome?
In tumor lysis syndrome, we will give aggressive hydration for the patient, and sometimes we'll give medication like allopurinol or rasparoquase also
Okay. So, what is
before.
the most concerning electrolyte disturbance in tumor lysis syndrome?
mm, Hyperkalemia,
Okay.
because it affects heart, causing arrhythmia.
Yes. How are you going to manage hyperkalemia?
Hyperkalemia, uh, ferrous will protect the heart, calcium bicarbonate, then we will give also uh, we will give nebulized Ventolin, and there is three treatment can be given for management of potassium apart from protect heart.
Okay. Thank you.
Okay, the last question, Dr. Salma. It's an advanced question. If the examiner asks you, he might give you the full mark. What criteria or score you know for tumor lysis syndrome? Do you know?
Criteria.
Yeah.
What you mean by criteria? You mean what I will find?
Yeah, criteria or score. Maybe Dr. Lamis can help you with the name of criteria you can use to diagnose tumor lysis syndrome.
For diagnosis.
Mm-hmm.
Mm, by apart from sign and symptom, we'll find hyperkalemia, hyperphosphatemia, hypocalcemia, and hyperuricemia also.
Okay. Do you know the name?
And liver function, renal function.
Yeah, and the name of this criteria. You are going to take the exam where? It's the
In the
same
hospital,
center. Same
capital,
center.
the capital
Yeah.
of Egypt.
Yeah. You know, so mention it, Dr. Lamis. If you know it, you can say it.
It's called Cairo Bishop, Cairo
Perfect.
Bishop
Yeah.
criteria.
Yeah. Cairo Bishop. Just remember it from the name. Cairo for the Cairo exam center. Okay. I remember the name by the way. So it came many times in Cairo, and the criteria is called Cairo Bishop, as Dr. Lamis mentioned. Okay. Now time to comment. Dr. Lamis, you can start. The skills in the
Uh,
chat box.
okay, thank you. So I think Dr. Salma at the end, like she got into the diagnosis, but she did not consider the tumor lysis. I'm commenting overall, then I'm going to say skill by skill. So I think she has the knowledge, but she was a bit hesitant while she was doing the case. So in terms of physical examination, I think like she covered most of the examination. One thing I wanted her to say, but she did like the vitals and the postural drop because this patient has been vomiting. So you checked the mouth. So you could have checked also like for any dry mucous membrane or signs of dehydration. But since you did the vitals and the postural drop, I think I'll give you a satisfactory examination because you covered like all the systems. Identify findings, satisfactory. In the clinical communication, few things happened during the history, I think.
Yes, I feel
So yeah, so the history, you were a little bit hesitant in the history, and it was not like quite organized and focused. Just a second, sorry. Sorry about that. So in the history, so it was a little bit hesitant, and you ask like few things to the patient. You say to the patient, no chest pain, no shortness of breath. So ask, do you any shortness of breath, any chest pain? There's something I noticed in regards to the vomiting. I think you analyze the vomiting regarding the kidney function because you had a deranged kidney function. So a good question to start with to know, have you had any problems with your kidney in the past to know if he has like any pre-existing condition? He would say no to you. Then you will know that the renal function derangement is related to the current episode. You did not focus on that. He mentioned to you that he has a recent diagnosis of lymphoma and he's taking chemotherapy, and that was the clue to the case. So you know that you are dealing to some complications related to the lymphoma and chemotherapy. One of them is infection, as you have mentioned, but also another differential is your tumor lysis syndrome. So you need to ask, when was your last dose? I want to ask you a few questions about your last chemotherapy, if you know. Do you have you second. So you ask like few questions in regards to the chemotherapy, like do you have any idea if any medication was given to you with the chemotherapy? Um, have you received the blood? Sorry, have you received any IV fluids when you went home? Were you drinking? Were you hydrating very well? Because these are your risk factors to develop tumor lysis syndrome. So just one or two questions. This was not the main diagnosis of the case, but it was your second differential. So it is good if you ask these questions to show that you are checking for the for tumor lysis syndrome. Otherwise, in the past medical history you covered, you did not ask about any drug history and you did not ask about the family history, even though the patient was not taking um, uh, medications apart from the chemotherapy, and the family history was insignificant, but just part of your systemic or being systematic in your history, you have to cover all the elements. Otherwise, the examiners will not like it and they will write, you did not ask about this, you did not ask about that. So I think just the history was somehow lacking. Okay, so regarding the clinical judgment, I think you were hesitant, and you gave basically one entity. You mentioned like infection, neutropenic sepsis, and CMV. So these go as one entity. I don't know if you remembered one of the things the patient mentioned to you. I had a tummy pain and I took some painkillers for that. So you could mention also like any interstitial nephritis as a complication of being on painkillers.
Okay.
Regarding the concerns, I think they were quite satisfactory. Um, just one thing, he asked you about the whether am I going to be admitted or not. So I think it is better from the start when you answer the concern to cover like is the patient going to be admitted or not. The team of doctor that will look after him and investigations and plan of management clearly. So usually concentrate whether you're going to admit or not. If you're not sure, you can say we are going to do the blood test and then we will evaluate whether you need admission or not. But in this patient, clearly he's a person on he's immunocompromised because he's on chemotherapy, he has lymphoma, and he's been having this vomiting, could be neutropenic sepsis infection. So definitely he needs to be admitted.
Yes.
Well, very satisfactory. So I think the clinical communication and the judgment and the differential diagnosis I will give borderline.
Yeah, this is what we call it linked skills. Because she didn't read the diagnosis, she didn't ask good in the history, she didn't ask or judge well, or clinical judgment, she didn't answer well, and the differential also wasn't that much perfect. So all of them will be affected once you are not reaching the correct diagnosis. Yes, the approach was good, I agree, and I could say the beginning was perfect. The analysis of the complaint, the relevant system, the GI question, all question you ask to the target, tummy pain, change of the bowel habit. Then you ask about the renal output. But the most important presentation of these patients, they will have dehydration, right? You couldn't ask. She told you that the amount is less. So consider this is dehydration. Patient is vomiting and the urine output is less. So what could be the complication will be there? Mostly he will be dehydrated. So the most important question here, are you compensating well? Did you take your the water okay? And did you feel dizzy when you stand from sitting position? He will tell you yes, doctor. Instead you ask anyone told you you are paler. I don't know what you are suspecting. Anemia, and anemia because of what? Right? Then you ask about the constitutional symptoms. When she asked you, doctor, not now, you told her, she asked you, do you have any change of your appetite? She told you, not recently. Okay, yes, this is good sign from the patient that he doesn't have it now. What about before? You should ask Dr. Salma. The things
Okay.
will be positive in the history. You have to focus on them. Like what? Like when she told you, I have lymphoma and I receive chemotherapy. You totally ignore it. Dr. Salma was volunteer, Dr. Lamin, sorry, was volunteer to tell you, I have taken my chemotherapy last week. I noticed that happened after the last dose of chemo or first dose of chemotherapy. Why you didn't ask these questions? This is your history. You have to take more and more whenever you have something positive. Don't skip it. Okay,
Okay.
Dr. Salma?
Yes, yes.
Yeah,
Last
it's
dose,
very
I didn't
important.
ask. Yes.
Not only when exactly started, anything positive in the history, you have to analyze it more.
Yes.
Okay, don't overlook it that like it's not something important. No, it's something could be the case. Here in this scenario, it's the case related to the first dose of chemotherapy. When you overlook it, you miss the case. She tried to help you at the end. She told you, doctor, I had this after I had the medication or the chemotherapy. She tried to help you, but be sure in the exam no one will help you. Even the examiner, she was very kind examiner. She's asking what could be related to the first dose of chemotherapy, and you couldn't reach the diagnosis, but she's trying to help you. No examiner will help you in this way unless the approach was good and he wants to give you a good mark. You got it? And because of that, you didn't do also the good examination of the dehydration. The vomiting as a complaint usually or sometimes will be complicated by dehydration. What I should examine as a dehydration, dry skin, dry mucous membrane, sunken eyes, right? Open your mouth, touch the skin trigger in the hand, dorsum of the hand, and the mucous membrane and sunken eyes. Sorry, so mucous membrane, sunken eye, dry the dorsum of the hand. These are the questions or the things you have to examine. Whenever you do one of them or all of them, be sure the examiner will know that you are examining properly. What if you miss them? He might give you for the abdominal examination some marks. Even you didn't hear the bowel sound here, which is very important. Patient is presented with tummy pain and vomiting. What could be there in the abdomen? Something alarming. Patient might have what? Sign obstruction, right?
Yes.
By the way, some case present with this, and at the end you'll discover that this patient was having intestinal obstruction. What to do? You have to do CT abdomen to conclude that. It's not the case today, but you have even one time to put your stethoscope in the bowel to listen for bowel sound. Or you can say, I would like to examine the bowel sound to auscultate for the bowel sound. You can offer for digital rectal, but you will not do it, so offer it just to rule out impact stool, again to rule out intestinal obstruction. What other differential you put in your mind? The AKI, acute kidney injury, right? Uremia can cause also vomiting. So I think this is the second differential. So tumor lysis syndrome, acute kidney injury, uremia, uremia related. And as you said, if you
Infection.
want infection related to neutropenic sepsis post chemotherapy, however, the chemotherapy related leukopenia or neutropenia will take time, not from first dose. But still, you can put infection as lymphoma patient. Any lymphoma patient will be immunocompromised, but not the case. The case here about tumor lysis. Okay, so the management, as you mentioned, it's
Even
aggressive.
even neutropenic sepsis scenario will not come like this, صح? Will come with high fever.
Exactly, yes. High
Yes.
fever. You will see also patient with high fever, hypotension, of course, acute kidney injury. Okay,
Okay.
and some patient they will have porticath or line, so the line will be infected. Not as a mandatory, but it's a like precipitating factor. So patient will have a line, the source of infection. So neutropenic sepsis mean there is source of infection, right? And this case will be, I think, not in this case because no other signs of infection, no fever here, right? She told you no fever.
No fever.
Yes,
Yeah.
37.5.
Yeah, perfect. So you can say just gastroenteritis. Even you can say drug-induced chemotherapy or most of the chemotherapy medication can lead to vomiting. Simply, the examiner will not say no. So I think if we repeat the differential in order, in the top differential will be tumor lysis, then AKI uremic vomiting or uremia signs and symptoms of vomiting. I mean AKI and uremia, and the third will be drug-induced vomiting. I will not put neutropenic sepsis or gastroenteritis unless there is signs of diarrhea, but it's not the case. Okay.
Okay.
What about the medication? You mentioned the non-pharmacological. What about the pharmacological option?
Uh,
How you give allopurinol?
uh, Albuterol for high uric acid, sometime given before chemotherapy,
What
before
medication will be given before? Is it allopurinol?
raspberry case.
Yes. It's
Yes,
a prophylactic medication.
yes,
Okay. Plus good hydration before starting the medication, the chemotherapy. In particular with with the lymphoma patient. Why? Because the turnover will be higher and expected to be higher with
yes,
lymphoma. Okay. Anyone
yes.
has a comment? You and Dr. Lamis?
No, I don't have any comment.
Dr. Lamis?
No, I have no further comments.
Okay, then just please write your scenario, Dr. Lamis, for Dr. Salma, or Dr. Salma for Dr. Lamis.
Okay,
I will read the comment quickly. Starting from, yeah, I think Dr. Riham was the first one to know the case. It was tumor lysis. Perfect, Dr. Riham. Tumor lysis 20S23, Zoom user, increase intracranial pressure because of what? Uremia, you mean? What, Dr. Omar? What chemo? Yes, this is very important comment. Don't overlook any medication patient received. Again, I always say and advise any positive finding in the history, you have to focus on them, analyze them. Don't overlook any finding in the history. Medication, surgery, procedure, any of these, you have to ask more about them. So, what chemo? Yes. When was the last? Which cycle? Any immunotherapy in the last 2 years? The differential neutropenic sepsis in main differential mask score should be calculated. Offer to say chemotherapy related organ related toxicity, pancreatitis, nephrotoxis, tumor lysis infection, medication admit, always admit, and hematology wards send immediate investigation for neutropenic sepsis, including blood culture and starting tazocin in than 1 hour, less than 1 hour from presentation as a part of sepsis. This can be revised after the blood come back, hematology review, hold chemo. If it was the case, but I don't think chemotherapy can fit the case here. Need more history about vomiting. She asked about the vomiting, the amount, the blood contain, and associated feeling sick, all of them. CNS lymphoma, no need to know what exactly the area of the lymphoma. Just lymphoma, it's the case. No need to mention CNS or where exactly. She mentioned already the patient is having lumps or bumps in the neck and other areas. Dr. Samira, tumor lysis, chemotherapy induced mucositis, drug side, opioid, steroid, CNS involvement, food poisoning, uremia. Yeah, I think the main problem for Dr. Lamis, I wrote it here because I will forget. she was preoccupied by a differential, which is gastroenteritis or neutropenic sepsis. That's why she couldn't focus what could be the case apart from this differential. Whenever you are preoccupied with the differential, difficult to reach to the diagnosis. Okay. Again, in my order, I will put tumor lysis, uremia, and AKI, and the third drug induced. I cannot put, or I couldn't say the neutropenic sepsis is one of the differential because
Yes,
it's the first cycle. Yes, Dr.
and
Mahmoud.
yes, and also Dr. Basim, how neutropenic sepsis cause vomiting, and what is the technique of neutropenic sepsis and vomiting? I think
Yeah,
it is
yes,
unlikely. Yes, I agree with your differential diagnosis, Dr. Basim. Tumor lysis syndrome was the first, and the second drug-induced nephrotoxicity cause acute kidney injury, and the third drug-induced vomiting. Yes,
perfect. I think
and and
Dr.
and and
Yeah,
also Dr. Basim, yes, in this scenario when came to Egypt,
exactly. Yeah, mention
yes,
your experience, please. What you know
yes,
about this case?
yes, the same. That's what the differential diagnosis, tumor lysis syndrome, and in examination, I think we have to listen to the heart. If there is any pericardial rub, just listen to the heart, and check also biphasic crepitation, and GVB is the most important. And in clinical judgment, we have to do ultrasound also to exclude any obstruction, because it may be the lymph node obstruct cause acute kidney injury. Uh, just that.
Okay, perfect. So you have two challenges in this case. Either patient AKI, volume overload,
Yes.
and failure, or
Because we don't know it is volume
exactly,
overload or
or severe
dehydration.
dehydration because of vomiting, and the patient will be dehydrated. So either this or that. Be careful
From
which one
yes,
the patient is having.
from up any edema in the face, any GVB enlargement, any pericardial rub, any
Perfect.
pleural effusion, any lower limb edema.
Perfect. Yes. All of them will be guide you to the overload
And
and then it's
also
the
yes,
bypassal
and
cracket. Yes.
yes, Dr. Basim, and also admission, IV fluid, respiratories. It is a treatment.
Yeah. And if the patient overloaded already, you can start dialysis.
Yes, according
Uh,
to the case.
yeah, along with the hyperkalemia or life-threatening arrhythmias.
Mhm. Yes, Dr. Basim.
Okay. Thank you, Dr. Mahmoud, because I know this case came before in Egypt, and I think you have it or some of your colleague.
Yes, one of my
But
colleague. It is the
yeah,
same.
but you know it, right?
Yes, I know it. It is the same. From outside, vomiting and elevated renal function.
Mhm.
And from inside, it was a lymphoma patient. Actually, it is a lymphoma patient, really. Lymph node, and from inside, it was the last session was since 2 weeks. It was the first dose, and the diagnosis was tumor lysis syndrome.
Okay, perfect.
But also we have to exclude the neutropenic sepsis with patient no fever, cause vomiting. I think it is not likely. It is unlikely in
Mhm.
this patient.
Yeah. You can say fever, patient present with fever. Now you can put the neutropenic sepsis on the top of your definition.
Yes. Mhm.
Patient has fever, hypotension, and signs of infection. Dr. Dina asked rhabdomyolysis as a differential. You cannot say rhabdomyolysis as a differential unless you have trauma or history of fall down or muscle injury, which is not the case.
And the pain when touching the
Muscle
muscle.
pain. Yeah.
Mm.
Dr. Ala, what is the reasonable differential again? So the first tumor lysis, uremia, AKI, and drug-induced vomiting. Chemotherapy, I mean. Your case scenario, Dr. Lamis, Mr. Omar, 62 years old, present with involuntary movement. Neutropenic sepsis could come without fever, cold sepsis, okay, but the patient vitals will not be normal. Cold sepsis could be with hypotension or borderline blood pressure. Let's revise the data. Here was 105 over 60, heart rate is 90. It's okay, borderline, temperature also normal. But I don't think, as Dr. Ahmed said, difficult to have vomiting in
Yes,
neutropenic
even with no fever, but where is the source of infection?
Dr. Bassem, can I just when I posted the comment, I can't see the comment because I rejoined again, I can't read my comment again.
Yeah,
But
okay.
what I was thinking is that this is the patient is has vomiting, likely he's dehydrated with possibility of AKI, could be possible secondary to to her dehydration based on the finding that was provided in the case. So usually in all chemotherapy patient, I, I don't know, here they would like you to rule out neutropenic sepsis almost all the time, because it's a very common, any patient on chemotherapy, you should rule this out, but you can list the others. So I listed, I think, chemotherapy related organ damage and tumor lysis, which you can't suspect tumor lysis without blood investigations. So you can't, this was my rationale of why, yeah, any patient with
it's a
the first
clinical, it's a
chemotherapy,
clinical diagnosis and laboratory one.
yeah.
But you have to put it one of your differential, and they like to put it in your top differential. Rhabdomyolysis as well, it came before in the basis, and the history was just run in marathon. So you can know or you can have the clue from the history. Okay. What I want to say, yes, you can put neutropenic, but not as a top differential. And this is the first chemotherapy dose. Just have received it 4 days ago.
Oh yeah, I didn't hear that that was the first chemotherapy dose. Yeah.
Yeah, and it was the
Mhm.
first.
Mhm.
So it's difficult to be there. However, you have to rule it out. But again, in the order or in order, you cannot put it in the top of your differential, okay?
Mhm.
Again, you have to put in your labs an investigation, CBC, and leukocytic count rule out infection. I didn't say this is not in your mind as a differential, but you cannot put it in the top of your differential, okay? In particular, if the patient just received the first dose of chemotherapy. Usually, those patients with chemotherapy, to have infection, first of all, they have to have source of infection. So indwelling catheter, Foley's catheter, or portacat, or center line, or he's hospitalized for a long time, so he will have hospital-acquired pneumonia, for example, or any catheter in the patient or procedure. So he has to have source of infection first, plus the chemotherapy as a frequency, plus stay in the hospital to have strong bacterial infection or resistant one. Otherwise, I cannot put it as a differential or in the top of my differential. Okay. Okay. I think we are done with this case. Anyone has comment or question before starting the next scenario? Clear for all? Dr. Lamis, you ready to start?
I'm ready to start.
Oh, here you go.
Hello. My name is Dr. Lamis. I'm one of the doctors in the clinic today. Sorry, where is the name? May I confirm you're Mr. Omar and you are 62 years old?
Yes, doctor.
Hello, Mr. Omar. I'm here to take some history and I will be examining you. Is this okay with you?
Okay.
Okay. So can you tell me what brought you to the hospital today?
Doctor, I feel that there is movement in my hand and my leg,
Okay.
mainly in my left hand.
Okay.
Yes, in arm and leg, all hand.
Okay. So can you tell
This
me
is
more
for
about
only 2 days now. It started now only 2 days ago.
me 2 days ago? Okay. And prior to that, you were completely fine.
Yes, between this movement, I'm okay.
Okay, right.
This is
So
starts suddenly.
started all of a sudden, okay. And you never had this
Yeah.
type of abnormal movement prior to these 2 days?
Yeah. What?
You never had these abnormal movements before. It only
No,
started
no.
to.
Yes, 2 days ago.
Okay,
It
so
starts suddenly.
you've mentioned it started suddenly, and it is in your left hand, right? Uh,
Yes.
and also in your leg. Is it the same leg?
Yes.
Okay. And can you describe the movement to me? Is it like a shakiness or is it like a sudden jerking?
Uh, Doctor, this movement is, I feel it is irregular movement and I cannot control. I, I
Okay,
feel I feel like my hands roll up from my body.
okay,
Yes.
okay. And is it only the left hand and the left leg?
Yes, I are in my arm and in my leg also.
Okay. What about the other
Only
side?
one side. No,
It's
it's normal. Only one side. Only left
okay,
side.
okay, right. And anything makes this movement better?
I feel by rest I will be okay, and when I am asleep I'm okay.
Okay.
And I
So
feel sometimes stress. I feel it increasing by stress.
okay, it increases by stress. Okay. And it's just a sudden, uncontrolled movement. You haven't noticed any shakiness in your body.
No, no, no.
Okay. So, along with this abnormal movement, have you noticed any shakiness in your body generally?
No, doctor.
Right. Okay. And any abnormal movement in your face?
No, doctor.
Okay. And you've mentioned to me it increases like with, does it increase with stress?
Yes, I feel it increase by stress. I will be better when I'm asleep or when I'm at rest.
Right, okay. And is it associated with any weakness in your body or numbness?
No, no,
Any change to your speech?
no, doctor.
Any headache?
No,
Any change in your vision?
no, doctor.
Any confusion?
No,
Okay. Any problem with your memory?
no.
And may I ask you if you have received any recent medication?
No, doctor.
Any recent illness?
No, no, doctor. I have no recent illness, but I have high blood sugar and diabetes for a long time, and I'm not control. I'm taking insulin.
You're taking insulin, okay. And during these episodes you've mentioned to me, have you had, sorry to ask you this, any loss of control of your waterworks or your bowel works?
No, doctor.
Okay. Any frothiness coming out of your mouth?
No, doctor.
Any rolling of your
Only
eyes?
very strong suddenly
Okay.
movement. I feel like my hand and my leg will be pulled.
Okay, right. Okay, I get that. Okay. And uh, is your blood sugar measured recently? Any problem with the blood sugar?
Yes, last HB1C 11.
How much? Sorry, I did not get it.
What?
Last one was how much? You've mentioned?
11. Yes, 11. When
It was 11. Okay, right. I'll be back again to your blood sugar, but I'm going to ask you like a few questions related to your general health. Have you noticed any increase in your body temperature?
no,
Any neck stiffness?
no,
Any fatigue or tiredness?
no, doctor.
Any weight changes?
No,
Any sweating?
No.
Any lumps or bumps?
No, doctor.
Any swelling in front of your
Hello?
neck? Yes, can you hear me? Am I audible?
No.
Any swelling in front of your neck?
Yes, now is okay.
Okay,
No, doctor.
okay. And do you have any shortness of breath?
No, doctor.
Any chest pain?
No.
Any racing of your heart?
No, doctor.
Any problem with your bowel works?
No, doctor.
Okay. Any problem with your
Dr.
Sorry, doctor.
Lamis, yes,
Some
please check your connection, please.
any skin changes?
No, doctor.
Okay. Any joint pain?
No, doctor.
Okay. Any muscle weakness?
No, doctor.
Okay. So you've mentioned to me that you have diabetes, and your last hemoglobin A1C was 11, and you are on insulin. Are you on regular follow-up?
No, doctor. I'm not going regular.
Okay. And um, you're not on regular follow-up.
Yes.
Is there any reason for that?
I am very far, doctor. So it's very
You're
difficult
very
for
far.
me to go. Yes.
Okay. So I will consider sorting this out for you, Mr. Omar. And apart from high blood sugar that is uncontrolled, do you have any other problems?
Yes, doctor. I have hypertension.
You have high blood pressure, okay. And is it controlled?
I am taking my medication. It's okay. I'm taking medicine called lisinopril.
Okay, lisinopril, okay. And what's your last reading? Is it
Last
within?
reading. Yes, it's not also good as يعني it's not good. It's like 160 over 100.
Okay, okay, okay. And do you have any hospital admission?
No, doctor.
Do you have any other problems?
No.
Okay. Um, what about your family history? Any family history of any abnormal movements or any problems?
No, doctor.
Okay. Right. May I ask you what do you do for a living?
I am teacher.
You're a teacher. And how is this movement problem and also your other diseases affecting your life, your daily life, and
Yes.
also your job?
Yes, doctor.
They're affecting you. So I'll try my best to help you with the occupational health doctor and see what support you need. May I ask you if you smoke?
Yes, doctor.
Do you smoke?
Yes, yes.
Okay. And how many cigarettes and for how long now you've been smoking?
10 cigarettes per day for around 3 to 4 years.
Okay. May I ask you to quit smoking because smoking has negative effects on your health, and if you want, I will refer you to the smoking cessation clinic.
Okay. Thank you.
Okay. What about alcohol intake?
No, doctor.
Okay. No alcohol. Okay. So before getting to examine you, I'd like just to check with few questions, Mr. Omar. So when you mentioned to me the hand, you said this left part of your body. Is it like all your hand, all the hand, the forearm, and the arm, or is it only your hand and your forearm?
No, doctor, I feel my arm. My arm from
All your
yes, from my
arm.
shoulder. I feel it proximal part mainly.
Okay. Mention to me you're not taking any other medication apart from your diabetes and your high blood pressure.
No.
Okay. Right. Can I examine you now?
Okay.
Okay. So I'd like to start my examination by the hand. So I'd like to look at the general condition of the patient generally. I would like to check if there's like any abnormal movement at rest. I'd like also to look at the face of the patient. If there's like any also abnormal movement in his face, then I'd like to start with the pulse, checking the pulse of the patient and the blood pressure. And also I want to offer postural drop in the hand as well. I will look for any nail changes, any palmar erythema, any pallor as well. Then I will come and check the eyes for any pallor, for any jaundice. I also want to check the neck, any swelling in front of the neck. And then I would like to do a neurological examination.
Okay.
Okay, so
All this
I will start my examination with the upper. Sorry?
Yes. Okay. Good.
2 minutes left.
Okay.
You want to do okay upper motor, upper examination, upper limb.
Yes, the upper limb. So I to check any pronation, and I would like just to offer any like sensation in the periphery, like to check for any peripheral neuropathy.
Okay, doctor.
And
Normal.
I would like to offer fundoscopy as well. Okay. So examination is normal.
Normal.
Okay. So Mr. Omer, can you please tell me what is your concern?
What I have, doctor?
Right. Okay. So from the history and examination, Mr. Omar, I think you most likely have some condition called diabetic hemichuria or hemibilismus. Do not mind the medical term. So this is a condition where there's abnormal, sudden jerking movement, like what you have been experiencing in your body. And this is sometimes it occurs as a complication of poorly controlled diabetes. I know you've been having trouble in the past a few months to control your blood sugar. So what I can do is we will form a team of doctor, including the nerve doctor, the gland doctor, specialized nurse, and then we will do some investigations for you to check the reason for these abnormal movement, and then we will manage. You will also involve the heart doctor for the control of your high blood pressure.
Time is up.
Okay.
Okay. Okay, Dr. Lamis, I will give you advice in the consent. Never ever be volunteer to explain something he didn't ask. Otherwise, he will waste another consent.
Okay.
Okay? So if he asks what I have, just tell him what you have. What he want
Okay.
to know, answer him in the next consent. Don't tell him we will do 1, 2, 3. No, no need.
Okay.
He doesn't know and he
I
doesn't
was
want,
just
okay?
trying to buy time, I think, because I just want to say like
Yeah,
all the
it will
time.
waste the other consent. He might ask you,
Okay.
doctor, can I drive? Can I do my job? Which is sometimes in the welfare, it might affect the concern. It might even affect the clinical judgment. Okay.
Okay.
Okay. Now the time for examiner. Examiner question, please. You can start, Dr. Salma.
Yes, present your case.
Mr. Omar is 62 years old. He has diabetes and also hypertension that are poorly controlled, and he's not on regular follow-up. He presented with sudden jerky movement of his left side of the body for the past 2 days that increase with stress and is relieved while he's resting or during his sleep. On examination, I did not appreciate any signs, and I did not identify any abnormal movement.
Okay. What is your differential diagnosis?
Okay. My differential diagnosis, it's first differential, I will put diabetic hemichorea hemibalismus, and especially that the patient has uncontrolled high blood pressure. His hemoglobin A1C is 11, blood sugar is not controlled. My second differential, it could be any acute stroke like a basal ganglia infarction affecting the movement of this patient, but like the presentation of the patient, the duration is not like consistent. I did not find any like a reason like for any drug induced chorea.
Okay, good.
I
What
think
investigation?
yes. So in terms of investigation, so apart from basic investigations in the form of full blood count, urea and electrolytes, liver function test, then I would like to do fasting lipid profile. I'd like to check hemoglobin A1C and a fasting glucose level. Then I would like specific investigations, imaging. I would like to offer CT brain and MRI, MRI brain.
Okay, good. You didn't want to do urine for keto?
Okay.
Urine for keto?
Yes, I would like to do as well urine for glycosuria and ketonuria.
Yes. Okay. Okay. What treatment?
So in terms of treatment, non-pharmacological in the form of education and counseling of this patient, physiotherapy, occupational therapy, and social support for this patient for the job. Then specific treatment and pharmacological treatment will include glycemic control for this patient and also blood pressure control. The glycemic control, depending on the severity, we will give insulin or medication. Then we have symptomatic treatment for his abnormal movement, and these can be in the form drugs that we can offer are haloperidol and risperidone.
Okay.
So
Other medication you want to use?
there's a third I cannot remember right now, but I remember the haloperidol and the risperidone.
Okay, good. Okay, thank you.
That's okay. I will ask here.
There is time?
No, still, yeah, 30 seconds. You will ask her, or I will ask her?
Okay, I will ask only one question. Where is the
Okay.
lesion? The hemibalismus?
It's in the basal ganglia.
Yes, in the basal ganglia in
Which
subthalamus
part?
nucleus.
Yes. You have
Yes.
to
Okay. This
specify.
I asked Dr. Basim.
Putamen and
No, subthalamic
Connect,
only. No.
connect up.
Subthalamic only nuclei. That's it. No need
Only,
to.
yes.
Subthalamic. Hemi sub. Always remember hemi
Okay.
means
Sub,
parts,
okay.
and you will specify sub. So sub for hemi or hemi for sub. Okay. My
Okay.
question for you: what else you want to manage to control this disease or this manifestation apart from pharmacological?
I want to control his blood glucose.
Perfect. So you have to control the underlying pathology or the underlying comorbidities, which are
Diabetes.
He's he's mainly his glucose for the diabetes because hyperglycemia is the main underlying
okay.
cause, and also I will control his blood pressure.
Yeah, perfect. And what else you could find along with these? Always with diabetes and hypertension, you might have. You mentioned stroke,
Metabolic
right?
syndrome,
Okay, so
hyperuricemia.
what in the
Okay.
what else?
Ischemic heart disease, maybe. You mean neurological or other complications?
No, no. As a complication to diabetes, metabolic complication to diabetes and hypertension, and they are a cause of stroke or predisposing factor.
Okay, it could be any ischemic heart disease, any arrhythmias, any metabolic syndrome.
Okay, so arrhythmias, AF, what
Yes,
else? So either thrombo or embolic. The thrombo,
yes.
the cause of thrombosis, for example, atherosclerosis, right? What are the most on the top of your differential as a cause of atherosclerosis in diabetes and hypertension? Both of them. It's one of the management plan for stroke and
Hyper
diabetes as well.
Okay,
hyper
it's
hyperlipidemia.
the Vicalotic.
Yes,
It is the Vicalotic.
this lipidemia, you have to mention it in your even investigation lipid profile. It's very
I think I
important.
mentioned it.
You mention if you mention it, it's okay. Oh, this is my mistake, but I'm focusing on this because it's one of the possible cause of this presentation. I think I'm not sure. Maybe this is for me. This is an stroke, right? So this is a
Okay,
stroke because of dyslipidemia or atherosclerosis or whatever because of alcohol to diabetes or hypertension. I don't know if the diabetic or there is something called diabetic hemiplegismus. I'm not sure about it, but this for me as a stroke. Let's listen to Dr. Lamis, Dr. Salma comment, then I will back to comment. Dr. Salma, you can comment now, please.
I think I was a little bit lost on the case.
No worry, you did perfect, by the way. Let's hear
Yes,
about the
very
comment.
good.
Yeah, perfect. Now, Dr.
Yes,
Salma.
yes. For me, I think all is perfect. Only need to ask about trauma history as a cause of also uh, their history of
Yes,
trauma. Then also other medication can help in improve symptom, tetrabenzene.
okay.
Yes. Otherwise, everything is very good.
Okay, so as a skills wise, you want to score here with me? Let's start for the physical examination. For me, she didn't have the time to examine perfect. And by the way, the examination steps will take time, not as in the online session. At
Yes,
least
of
at
course.
least 4 minutes. You started to examine at 11 minutes, I think, or 12, which is very lacking time to expose all the finding in this patient, right? At least, if not unsatisfactory, they can give you borderline. The identified finding, yeah, because of no manifestation right now, they might forgive about that. But be sure you have to examine the pulse. You might have AF as an association, and they might minus you as the only positive finding in the examination. Most of those patients with comorbidities, they might have AF. Be sure you examine the
Yes.
pulse.
Yes, I offered the pulse and the blood pressure and the postural drops in
Perfect. If you offer
patient.
it, not only offer, you have to examine the pulse by your hands, the radial pulse.
Okay.
Okay, and auscultation to the apex. If you could pick up the AF or irregularity, they will give you a satisfactory in the identified finding. Why? Because you don't have other finding as hemipalesmus right now or hemichorea. And then, but you have to do the neurological examination to empower flex coordination sensation. Why? Because you might put stroke one of your differential. Even Babinski you have to do as upgoing. Because you have left side, right? Or unilateral, there is
Yeah.
neurological deficit. So it might be a stroke. And this one complicating the stroke. So again, I identify the finding. I could say also this is borderline. Clinical communication was perfect, apart from what do you think you miss in the communication?
The
Trauma,
driving.
perfect. Driving it's a mandatory,
Yes, the
as well
driving.
as the trauma, as Dr. Salma said. And for me, I will add the diabetic complication while
Even though
taking.
I wrote them in my paper, but I think you know what
Yeah,
went wrong
see,
with Ms. Bassam and Dr. Selma is I went into the case and I thought this would be Parkinson, like the age and the abnormal movement, and then when when it didn't turn to be Parkinson, I
always.
started to panic.
Yeah, this is our all of us. Whenever you are preoccupied with a diagnosis, you cannot focus on the others.
Yes,
I
I
guess also
agree.
this is Parkinson, and you thought this is because of unilateral presentation. It could be peripheral more than or distal different more than the proximal, but you was or you were shocked or surprised when
I
she
was
said
I
it's
was panicking to be
dancing
honest.
one. Yeah. So it's okay, but at least you learned the lesson today. It's not only Parkinson. Be ready to have this or that. So either bell rolling for Parkinson or dancing an involuntary, purposeless movement. By the way, Huntington here, second differential or third differential. You have to put Huntington as differential. They like Huntington as a topic, okay? Particularly if you have family history. But you can say again is family history. Again is sorry, Huntington, no family history. But Huntington as a Korea, one of the most important differential you have to put. Let's go back to the chemical communication. So trauma and
And
the
driving.
driving and the stroke, mini stroke, heart attack. All this question means you are confirming the diabetic or the poorly controlled diabetes in this patient. He's already poorly controlled by his hemoglobin A1C, but he might have previous stroke. So you can say this is a case of stroke based on his past history of stroke. Okay,
Okay.
if you could pick up history of stroke in the past, mini stroke or stroke, both of them equal to stroke. The second thing, the heart attack. If there is history of heart attack, means ischemic heart disease, means AF as a complication or arrhythmias. Don't forget them. And of course, the peripheral neuropathy. I think this was asked during the analysis of the neurological claudication, impotence. You have a lot nephropathy. Did you ask about the fruitness
I asked about the waterworks in general, not specifically
in
about
general?
fruit.
Yeah.
Yeah.
Whenever you have diabetes or history of diabetes, in your case, put the in the systemic review the question of the macro and microvascular complication. During taking them from up downward, put the macro in front of your eyes. I could put the stroke and mini stroke in the, for example, in the head or the CNS question. Heart attack with heart awareness or awareness of heartbeat and the chest pain. The nephropathy I will ask during water work, in particular for witness of diarrhea. Impotence, autonomic neuropathy with dizziness from standing or standing after standing from sitting position. So you can enroll all of them or any one of them during taking the systemic review. The last thing, the hypoglycemia. Did he have any of them? Did he have any hypoglycemic attack? Why again? I will address the driving in the same time. So two reasons for stopping or holding the driving: hypoglycemia and the abnormal movement itself. Okay. So the chemical communication, I want to give you the full mark, but unfortunately, there is some lack
A borderline.
in the
Yes.
systemic review. Again, borderline. So you might take a borderline olds. Clinical judgment was perfect. You give the case, but I prefer to say the stroke before diabetic. I don't know if there is something medical term called diabetic hemichorea.
To be honest, I'm not sure if Dr.
Yeah, I
Selma
think.
has like the exact recall of where this case came from, but I remember like I heard this case. It was like practiced by someone who had a recall of the cases that came in Rawalpindi in Pakistan. So they had this like hemibilismus. It was like a similar, almost a similar case.
Okay.
They said it was,
Diabetic
yeah,
hemichorea hemiplegisma. There is a term.
yes,
It's a
hemi.
rare, listen, a rare involuntary movement disorder in uncontrolled diabetes, featuring sudden jerky movement in one side of the body. So it's correct, but it's a rare one. I don't know how was the calibration, Dr. Selma. Is it diabetic hemichorea hemiplegismus or it was stroke in the subthalamic nuclei, and this is a case of acute stroke? Dr. Selma, are you with us?
I think Dr.
Anyway,
Bassem, this is
yeah.
the main topic is hemiplegismus, and the cause may be high blood sugar,
Okay, perfect. Yeah,
stroke, and
yeah,
and usually it is a rare condition, really,
yeah,
not
yeah.
a case. It
But
came
at
once,
least to mention hemiplegismus, this is your case.
yes,
And the
maybe
base,
due to stroke, high blood sugar, maybe
perfect.
due
Yeah, I agree to
infection.
say that. Okay,
Mhm.
perfect. So we agreed to say this is a case of hemiplegismus for differential.
Yes,
What are the causes? Either the diabetes itself, or stroke,
stroke, maybe infection,
or trauma,
mm,
or infection.
or
But
trauma.
yeah, or drug induced. And
Yes,
Huntington, you can say Huntington. Again, it's Huntington, no family history. If there is family history, you can put the Huntington in the top of your definition because this is the same movement of Huntington.
yes.
Both
I
the same.
think in this case, Dr. Bassem came in Pakistan. She
Okay.
had a family history of Huntington Korea. So
First.
the concern of the surrogate was, is it Huntington? Huntington? No,
Yeah.
it is because it is acute since 2 days only.
But still, I have to rule out
Yes,
Huntington.
we have to rule
Yeah.
out. I think by MRI.
Perfect.
I think or genetic testing. I don't know.
The Huntington as a clinical and genetic.
Yes, clinical and genetic, and we should ask also about the memory, any memory changes recently,
And
ممكن
any.
behavioral change, yes.
And
ممكن
shall
أقول
we
شيء.
rule out rheumatic fever also as well?
Yes, rheumatic and systemic lupus.
Yeah.
As a Korea cause, yes. Again, it's a
Mm.
Korea cause.
طيب بس
Yes.
موضوع
Dr.
الصحة
Hint.
إنه لا أنا آسفة صوتي تعبان.
Salamat.
إذا كان الأونست أكيوت الله
Yes.
يسعدكم ما تستخدموا differential degenerative disease.
Like what?
Cause acute
Like Huntington?
Yes,
Huntington.
never say.
Yeah.
Patient
Okay.
started Korea 2 days. If you said Huntington, you will shock your examiner.
Okay.
Okay?
Mhm.
Acute, sudden, I agree with you. Vascular, metabolic, toxic, traumatic.
Okay.
أربعة.
Mm.
ما يعني if you said this he will respect no you took the history of sudden acute onset. So you said vascular stroke, metabolic diabetic, induced traumatic, toxic اللي هي drug أو alcoholic or whatsoever. This is the differential diagnosis of any neurological acute sudden. بس يعني Huntington it is degenerative long standing
Yes.
gradual onset progressive. هلا أنا I agree مع فكرة إنه الهانتنجتون is a hot topic for us in
Yeah, yeah.
cases. بس if it is acute 2 days of onset think يعني too much before. And the family history here of positive Huntington is only explaining concern
إنه دكتور do you think I'm also affected؟ نحن بنعرف إنه الهانتنجتون يعني it is autosomal I think dominant صح؟
Yeah,
dominant.
dominant, and
with
there is
early
anticipation.
penetration. So
Yeah.
we will tell her in view of the onset that you
Mhm.
had, but still we better involve a genetist to make sure that you don't
Yes.
carry the risk to develop. تمام؟
Perfect. Yes.
for this. وطبعا أنا إذا سألت بالفاميلي history how much was the age of your mother، فإذا مثلا at age of 50 هي هلا عمرها 30 I'm dealing with a patient 30 or
Yes.
40 I will tell her usually this disease happen at an earlier age, so we will involve a genetist, but for the time being the acute or short term onset of your symptoms could be explained better by كذا 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 كذا
Yes.
whatsoever I'm suspecting.
Okay.
فأنا يعني I think this is just because of the onset. حيكون كتير صعب ذكر الكوري.
Yes. Okay. Thank you, Dr. And
لا
سلامات again.
like
Recovery soon.
like the case came in Alex, Dr. Basim. The case
Yeah.
was memory change since 3 days.
Okay.
And the concern of the surrogate was, is it Alzheimer disease? So it is unlikely to be Alzheimer because
Yes. Alzheimer will be long-term disease.
Yes, Dr. Basim.
So you can put, you want to say TGA, right?
In memory change?
Yeah, TGA as a cute one.
Yes, I think it was also different diagnosis.
And stroke and
yes,
trauma as
stroke or TIA. Yes.
TIA and TGA. Transient
TGA.
global amnesia.
Yes.
Okay. Okay, thank you, Dr. Mahmoud. Let's go back to the comment, the scale, sorry. So the differential, I think you mentioned the yeah, so it's satisfactory. Sorry, Dr. Ramis. I will give you satisfactory in the borderline and in the differential, sorry. Concern, as I said, don't judge all the concern by yourself. You have to give her a chance to ask you another question or concern. They might have 5, 4, 3. It's not only a matter of one concern. Some of them asking one concern. According to the case calibration, yeah, it might be long case with a complex history and manifestation, examination steps, but give her chance to express all her concerns. Otherwise, they might minus you. Don't be volunteer to say, I will admit, I will run investigation, imaging, blood tests, whatever. Maybe this is not her concern. So the main concern for the patient may be driving, family, running, or something serious, the job, the drive, as I said, the driving. Okay, give her chance to express. I give you borderline the concern, the welfare for the driving. I can give you borderline as well, because if this patient is driving, in particular if he's heavy driver or heavy vehicle driver, you will be in trouble, right? Take care. The job or the driving might be very serious in such condition. This abnormal movement, the patient cannot control the driving with it. Dr. Lamis, you can hear me?
Yes, I can hear you, Dr. Basim.
Okay. You have any question regarding this?
No, thank you. I think it was a very nice case, so thank you, Dr. Salma.
Yeah, it's as we said, it's a rare case, but at least you know there is a case of hemiplegismus. You have to rule it out, or it can come as Parkinson, as you mentioned earlier, or the Korea itself as a Huntington. It came before, so pretty to mention this and that. But the history was perfect initially. Later on, the systemic review was lacking some of the complication for diabetes. This is my only comment. And of course, to be faster, to finish and to start examination earlier. You started late, which will not help you to get all marks in the skills of examination. Okay? Yeah, this is the time to comment if you have any question or anyone has a comment. Any question?
No, thank you, Dr. Basim.
Is it clear for all? Trauma is important question in any abnormal movement or any neurological manifestation. Don't forget them. Even the syncope. Whenever the patient fall down or lost the consciousness, you have to ask about the trauma. Did you hit your head? Did you hit your head? It's important. One of the welfare points. They might minus you if you couldn't ask. So 16 out of 28, same as Dr. Salma score. All of you knows how to they are judging the performance. I'm considering two examiner with the same judgments. So both of them borderline means two marks. Both of them satisfactory means 4 marks. Both of them unsatisfactory 0. Okay? I'm assuming two examiner with the same judgment, but this is not happened. Usually some of them give the satisfactory, one borderline, or one borderline, the other unsatisfactory. Very rare. One will give you the satisfactory and the other will give you unsatisfactory. Mean there is discrepancy and something went wrong during the calibration or during the judgment, which is not commonly happen. Okay. Let's go to the commented chat box. I think Dr. Samira, right? Someone wrote it initially, and I hope the participants are not looking at the chat box because it was written there. The first one, Dr. Samira, non-ketotic hyperglycemic induced hemiplegismus. So again, we will say hemiplegismus for differential. You can put non-ketotic, but why non-ketotic will cause as one side as a metabolic? I'm not sure to be unilateral. So the patient will have diffuse, but why on one side? I'm not sure about it. Need a neurological advance judgment. Examination, honk, stroke. So stroke, okay, I agree, Dr. Musa. Differential hemiplegismus secondary to HHS, hyperosmolar hyperketotic state. Stroke, tumor will not be as acute. Tumor will be for long term or chronic course. Dr. Musa, acute since 2 days again. Yes, I agree. Also look for dehydration signs, offer urine output measure beside blood sugar and ECG. That's why I prefer always to start general, specific, bedside, imaging, invasive. You will not forget any of them whenever you start in this way. The bedside here is very important to mention urine dipstick, which is important for the diabetes and diabetic patient to roll out ketonuria and, for example, DKA. If you will not say bedside, you will forget it. Yes, you will say hemoglobin A1C, you will say, but the ECG also one of the bedside tests, the Holter, the echo. If you want to confirm arrhythmias or ischemic heart disease, please answer in the systematic way. He will give you good mark. She is good history taker, but slow. I agree. So I think she learned the lesson because she got shocked when she had the proximal movement, not distal. Ask always from trauma deriving. We mentioned this. Thank you. Admit ABC approach, fluid, insulin, electrolyte. I think for the ABC, if the patient is confused or admitted or presented in the first hours or shocked, any vital signs affected. But here, no need to mention ABCD approach. Acute, this is 2 days history, so it's not that much acute. Anyway, if there is something affected like breathing, circulation, or the confusion or the GCS, you have to say ABCD approach. Any vitals affected, you have to say ABCD approach. Subthalamic nucleus, yes, lacunar infarct. Dr. Salma, what is this name of the other medication that may improve the symptoms? Tetra, I think someone can write it in the chat box. Tetranidazine, right? Dr. Salma? Very nice informative case. Thank you, Dr. Samir.
كان الدواء اسمه تترا بينازين.
Yeah.
تترابينازين.
بينازين.
حتى هلا اذا لقيت السبيلنج الصح تبعه بنبعته مكتوب صح.
Yeah, better. Yes, better. Very nice. Huntington will not present acutely. I think yes, this is what Dr. Hint corrected. But it's, as Dr. Hint said, it's one of the hot topic. You have to roll it out either from the onset or from the family history. Okay, so the onset will be different, longer duration, chronic course, progressive family history, behavioral change, memory change. Okay, tetrabenazine. Dr. Hind mentioned it. Okay, and the tetrabenazine. Okay, thank you, Dr. Hind. Anyone want to comment?
Yes, Dr. Basim, why admission in this case?
Admission if you suspect stroke.
But we did already pronotor drift negative, so I think no stroke.
خلينا نقول الادميشن لانه acute onset neurological symptom. يعني by itself any acute neurological onset ما قلت لك 4 causes كلياتهم serious causes. Whether it is toxic, whether it is drug induced, you need to deal with it quickly. Whether it is traumatic ولا vascular ولا حتى metabolic. You need to admit لأنه حتى لو كان diabetic related, you need to achieve
Yes.
control of
Aggressive.
diabetes very quickly, aggressively, لأنه otherwise it will become irreversible كل ما أخذت وقت أكتر. Since it is acute من هون the concept of admission, not because of the cause itself. Acute onset neurological, we need to admit, treat, and find out the cause. Why he has this acute. تمام. هلا لو كانت مثلا هانتنغتون كوريا حتقولي طب أنا I cannot do anything, why to admit؟ حلك yeah you are right يعني everything can be done OPD. تمام.
Yes.
Acute you need to admit since it is acute.
Yeah. Whenever you have neurological deficit, please admit the patient, refer to neurology emergency. You might have a stroke. It might be in the window. Not,
Yes,
of course, 2 days, maybe 1 day. But never ever miss the stroke as a differential whenever you have neurological deficits. Okay?
Okay, Dr. Basim.
Multidisciplinary, of course, on the top of your management plan. Okay, anyone has a question? Dr. Ahda, I wrote the medication again, tetrabenazine, vesicular monoamine transporter 2, BMAT2 inhibitor. I challenge you can remember the medication or mechanism of action. At least remember the medication name. Or remember the other mechanism of action. Of course, the optimum to remember both, but I think it's difficult. And since the case is not common, and we are not practicing it more, but the lucky one who can practice this case and he will remember the medication name. Okay, thank you, Dr. Lamis, Dr. Salma. Anyone has a question? Dr. Hind, Dr. Mahmoud, everyone attend today.
Thank you, Dr. Basim. Thank you very much.
Most welcome. Thank you, Dr. Okay, thank you, everyone. See you tomorrow, inshallah, with Communication Day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.